introduction and for letting me speak today about this topic. I know the topic is a little different than what we usually do for these rounds, but it's very timely as well because as I think everyone on the chat currently knows, we're due for accreditation review. So I thought it'd be a good time to outline the status of our program, the structure, where we're headed, just so that we're all on the same page. And along those lines, I would also appreciate any feedback you might have for ongoing quality improvement. Um, so as Anna outlined, and thank you for that land acknowledgement, we're gathered on the traditional, ancestral, and unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. These are our objectives for today. Many people on the chat will have some knowledge about these, about how our program is run, but hopefully you'll get some more information. And beyond accreditation, I think it's, the fellows are an important component of our BC network. Not only do they do most of the presentations, but they're also the future members of our network. So knowing how we're training our future colleagues, I think is very important. So we'll talk about the curriculum, how we select trainees into the program, how we assess them, how we address issues related to competency or professionalism, since we just developed a policy on that. We'll talk about our governance and our committees, our policies, resources for directing fellows towards wellness resources or wellness supports, and mechanisms by which you can provide feedback and by which we can communicate as program stakeholders. So what sets us apart as an area of focused competency? And as you may know, we've actually, at St. Paul's at least, we've been training thrombosis fellows, myself included, for several years, going back to maybe at least 2020 or even before that. We acquired our accreditation status in 2024, just recently. And what that means now is that we're recognized as a formal standardized training program by the Royal College of Physicians and Surgeons. And that is the definition of an area of focused competency. Essentially, it's a subspecialty focused training program that is actually recognized by the college. Accordingly, we abide by standards of accreditation, and the college sets these forth every few years. We're actually due for a revision on these, but as you can tell, there's general standards and there's also thrombosis specific standards of accreditation that outline variables such as how the program should be structured, governed, how the learning environment should be conducted, our resources, how teachers should behave, and how the program should undergo ongoing quality improvement and standardization. And so our program is designed on the basis of these standards, and we must be adherent to them. So the other variable that's different now is not only are we standardized in the way that we train our fellows, but also our fellows can acquire a diploma to recognize that there are now nationally recognized experts in the field of thrombosis medicine. To give you a bit of a historical context as to how the AFC and thrombosis medicine evolved, it was actually not too long ago, a decade ago, that adult thrombosis medicine as a specialty was recognized as a discipline of area focused competency by the Royal College. And in the subsequent years, three main programs developed. It was the Ottawa, McMaster, and McGill program in Ontario and Quebec. It's unclear based on what I've looked into exactly when exactly those programs achieved their formal accreditation. My impression based from what I gather is in around 2016 to 2020 or so. Others in this chat might know a bit more. But either way, it wasn't until now that we have a program in Western Canada. And as you can tell, what's really exciting is we're the only program west of Ontario. So we have geographically, we have a very large area to cover in terms of training fellows. Obviously, fellows can nationally go to any program in the country, but it's nice that we now have a program in Western Canada with some representation in BC. Let's talk about our curriculum. So our clinical curriculum has evolved over the years. St. Paul's Hospital remains our main rotation. We have both ambulatory and inpatient components, and I'm the site lead for this rotation. St. Paul's, since it's our main rotation where the fellows spent most of their blocks, is the site where fellows really gain their evolving responsibility. Towards the end of the year, they manage the clinic and inpatient service as junior attendings. They really take on a leadership role, and we can assess their evolving responsibility through this longitudinal somewhat rotation. They also spend some time at VGH, which is a very valuable rotation because it provides some exposures that we don't get at St. Paul. So the fellows will do clinics in the mornings, and then in the afternoons, they will join the VGH hematology service to perform thrombosis consults or to supervise junior trainees on completing thrombosis consults. And what's nice about that is that they have exposure to patients, for instance, neurosurgical patients, trauma patients, patients with organ transplant, these particular populations that we don't quite get exposure to at St. Paul's. And Erica Peterson is the site lead for VGH. And this is a new rotation since we became accredited. The Surrey Memorial Hospital rotation is a full-time thrombosis clinic, and it's all ambulatory, and it's led by Faraz Moin Vasiri. And it provides a nice, a busy outpatient, more community-based thrombosis exposure with a very diverse ethnocultural population. Fellows also spend 1 to 2 blocks on elective, so they have the opportunity to pursue any type of training that they may wish that's related to thrombosis. Historically, our fellows have chosen to go to AFC sites elsewhere to get out-of-province exposure in thrombosis. But there is no strong, if they find that any type of rotation that's related to thrombosis, we can make that work. So as you can tell, there's diversity in the clinical exposure, and every site and every rotation provides fellows a very unique experience. They also spend 1 block on a dedicated scholarly rotation where they're protected from all clinical work and they focus on scholarly work, be it research or quality improvement or medical education. Throughout the year, there's a lot of additional learning opportunities in titration of warfarin, management of INR. That can be done at all 3 sites. At St. Paul's, the fellows gain experience in providing telephone advice, which I've repeatedly heard from fellows is a unique skill, and we all know this. It's a unique skill in itself, but it's important to get that experience before fellows go into into independent practice. Along those lines, as I alluded to at St. Paul's, as the year progresses, they get some exposure to triaging, to managing of a clinic, to really take on a managerial and leadership role within the clinical setting. They can also observe IR procedures. I think Gord actually has seen an IVC filter placement. They can see catheter-directed lysis, things like that. And they spend 1 to 2 days on the ultrasound department at St. Paul's observing diagnostics for DVT. Our academic curriculum is also growing with time. As you may have noticed, most of our academic sessions are actually led by the trainees, which in itself I think is helpful to get them to learn not only to present, but also to become experts in whatever topic they're presenting on. The majority of the academic work is spent on the BC Thrombosis Network presentations, and they present an M&M or an interesting case once per year. At St. Paul's, they are also involved in teaching junior learners on the CTU morning report. So they'll present a thrombosis case in a CTU morning report format to the learners. They attend journal club. Usually the journal club actually is presented by our off-service trainee. The fellow will present maybe 2 or 3 times per year, but they get that journal club experience as well. And as I mentioned, they're involved in a scholarly project. And really, this is a year-long endeavor with a dedicated scholarly block, and there's diversity in what they can pursue. And they're funded for attending conferences, even if they haven't completed their project. As you may know, Gord is an excellent example of a fellow who has really taken this on in full force. He completed a project with Hamish Nicholson in DOAC validation, assay validation. Sorry, not DOAC assay, lupus anticoagulant assay validation, and actually had a chance to present it at the THSNA conference in Portland in March as an oral presentation. And beyond that, he was invited to be a moderator at a separate session. So the conference attendance, I think, has been highly valuable for our trainees. We have in terms of faculty-led sessions, we take a lot of pride in our hematopathology academic half-day rotation. And I want to give Hamish Nicholson full credit for this because he has built an excellent curriculum on topics that are key for any thrombosis expert regarding assay evaluation, hematopathological basis of thrombosis, and anticoagulant management. So fellows will receive experience with coagulation physiology, antiphospholipid antibody testing, hereditary thrombophilias, anticoagulant monitoring assays like anti-10A monitoring, DOAC levels, etc., D-dimer intricacies, heparin-induced thrombocytopenias, and there's also bench activities within that. And that's 10 half days in the start of the academic year. And maybe I speak for myself, but it becomes clear as the fellow progresses that they are truly a hematopathology expert beyond me by the time they are done these half days. I actually frequently will ask Gord intricate details regarding heme path topics that he actually knows quite well. And I think part of it is our half day. And the fellow actually has a chance to present on topics to the laboratory technicians related to thrombosis medicine. So additional presentations from that end. Our didactic lecture series, we are building slowly. The idea is to present on topics that are less frequently encountered or taught in a clinical setting. For instance, John Doring actually is now presenting the yearly epidemiology of VTE lecture to our fellows. Erica presents on a couple of topics. Early on in the academic year, there's a presentation on anticoagulants and reversal agents. That's in conjunction with the Hematopathology Fellowship Program, and as well as cancer-associated VTE. Next year, I'll be adding on a topic on a lecture on CTEPH. And as you can see, there's a lot of room for additional didactic lectures. And I suspect this will be one of the variables that will be encouraged for us to pursue further from the Royal College. So every faculty member is welcome to present on a topic, and hopefully we can build this further in the coming years. Any questions on the curriculum before I move on? No, good. So I also wanted to chat a bit about how we select and assess and promote our fellows. We've actually spent a lot of time optimizing our selection process because our applicant pool, I mean, it's not large yet, but it can become large if we start accepting visa trainees, and we can only accept up to 2 fellows per year. So we need to be standardized and selective about who we allow into our program. And accordingly, we actually put together a policy to outline how we select our fellows. And as I'll get to later, all these policies are accessible to you through our shared Google Drive. But we also have a selection committee. This is just a copy of the terms of reference. Just I know it's too little to see, but it's also accessible to you in the Google Drive. The eligibility criteria for our fellows to join the program, they need to be certified in internal medicine or emergency medicine. And by the way, these are eligibility criteria that are set forth by the college. This first one. They also must demonstrate proof of third-party funding to be able to cover their entire salary, because obviously free labor is not legal. So fellows must show proof of funding. Thus far, our fellows have been GIM trained, so they receive their funding through the GIM fellowship to complete their 5th year. We are not yet accepting international or visa trainees just because we're a brand new program and we just wanted to make sure our program is is running smoothly because before we open the doors, but I receive 4 to 5 emails a year from interested visa trainees over the last 2 years. So I anticipate that in the near future we will open those doors, and once we open the floodgates, our applicant pool will drastically increase. In terms of our application process, briefly, the any prospective candidate will submit an application package to me consisting of a CV, letter of intent, uh, the basic things of an application. Um, and then our selection committee reviews all applications, and those that meet eligibility criteria that I've outlined, all of them are invited to interview. And the interview is done in a standardized format. Some of you, I think, Rob Schmidt is on the chat, has been part of our interview um, or selection committee. So you might be aware of this. But the bottom line is it's done on a standardized basis with a selection committee that's selected on a rotating basis annually. And we then rank our trainees on the basis of these criteria. So their academic record, history of scholarly accomplishments or interests. Um, Importantly, we try to assess that our applicants' learning goals align with our curriculum. For instance, as you saw, our curriculum is primarily clinical. So if we have an applicant who is primarily focused on research, then perhaps this is not the right program for them. We also assess reference letters and their performance on the interview. And as I mentioned, we are accepting up to 2 trainees per year. This process takes forth in around November to December of the preceding academic year. Any faculty is welcome to be part of the selection committee each year. So I usually send out an email with invitations, and you're welcome to be part of it. How do we assess fellows? And this is a very important component of our program because we need to assess fellows to ensure that they're meeting the competency training requirements that are set forth by the college as a standardized program. And so we have multiple ways we do that to ensure that the fellow has reached all competencies by the end of the academic year. In terms of their clinical competency, as you know, at the end of each block, the fellow receives in-person feedback from the site lead. So that's myself while I'm here, or Erica Peterson at VGH, or for us, and that's in Surrey. They also, attendings will complete end of block ITERs. And the items in the ITERs are specific to the competencies that the college wants us to evaluate. The ITERs are supplementary to the competency portfolio, which you may have encountered as teaching faculty. And the portfolio essentially, I think of similar to EPAs, right? There are clinical activities that the fellow completes, and then as faculty, we sign off on them successfully completing them. It's a pass-fail type of situation, just to sign off on variable items. The fellows also meet with me on a quarterly basis, where we assess their progress, their ITERs, if there's any concerns with competency, and how they're progressing with their competency portfolio. And we have a formal competency committee who assesses fellows biannually. There's a mid-block or mid-year review, and then also end-of-year review before they graduate. And this is our current competency committee. It's myself, Tony, Kirat, Erica, and Hamish. As you can tell, there's good representation from all learning sites. In terms of assessment of our academic activities, like the BC Network rounds, we actually give the fellow the evaluation forms we fill out at the end of the BC Networks. They actually go to the fellow anonymously for their feedback on how their presentations went. On a similar basis, when they present at the CTU Morning Report, the junior learners on the CTUs will complete a Qualtrics survey that goes to the fellow at the end of their presentation so that they know how they're doing on their academic activities. And then once the fellow has completed all competency requirements, they graduate. And I thank you, Jordan, for allowing me to share this. Jordan was our first Thrombosis fellow, and this is proof of concept that our fellowship program works. And Jordan graduated and got her diploma certificate for adult thrombosis medicine, recognized by the college, as well as a certificate through UBC, because it's obviously a formal UBC program. And Gord is well on his way to acquiring certificates as well. Any questions about assessment? Okay. All right. In terms of addressing issues related to competency, now that we're talking about assessment or professionalism, this is something that I foresee will be a rare event in our program. Our fellows are highly selected, and they're in our uh, historical experience, they've been excellent. But we need to be prepared for when competency issues arise or professionalism issues, not only for our sake, but that of the fellows, most importantly, to ensure that the process is standardized, transparent, and fair. Uh, so in terms of your responsibilities as teaching faculty, if you encounter a fellow who is experiencing deficits in either competency or professionalism, first I'd like to highlight that we have just published a protocol for this. Again, accessible through the Google Drive that provides detail, but I thought I'd highlight the main points. So for minor gaps in competency or professionalism, and as examples, those are things like, for instance, the fellow had a minor gap in their assessment of a patient, or it was non-trivial but not major deficits in knowledge. Maybe not didn't know the details of a specific landmark trial, etc. Or minor gaps in professionalism, like they were late to one or two academic sessions, etc. For those more minor issues, this is generally handled internally through in-person timely feedback between the supervisor and the trainee. If there are recurring deficits, then it's definitely encouraged that they be added on to the written portion of the IDER. As you can tell, there's always an area for comments, and relate to the site lead on a sooner rather than later, so that the site lead can give mid-block feedback and review the fellow earlier, more formally. If you encounter more major competency or professionalism gaps, then the process is more extensive. And examples of major competency professionalism gaps, as you can imagine, are major gaps in knowledge. For instance, the fellow didn't know that provoked VTE is treated for 3 months with anticoagulation, for instance, or they are taking way longer than expected to complete the daily tasks, or they are missing large components of the assessment and plan of a patient, or they're not assessing patients properly, or being unsafe. And from a professionalism standpoint, the similar severity, like they are being rude, or there's serious issues with the way they behave, right? And again, the guidelines will provide more examples on that if you review them in detail. But for these type of issues, then obviously still the supervisor is encouraged to provide feedback to the trainee and document it on the IDER. But then it's important that I be alerted, or the program director be alerted, whoever they may be in the future. And then what I do accordingly is I promptly meet with the fellow to discuss the issue, screen for any wellness problems that might be prompting the deficits, and then I call for an urgent competency committee review for assessment. And we formulate a remediation plan. So that might involve enhanced supervision or slight changes to their curriculum to help support them. And if there's major gaps in professionalism, we also involve PGME, in which sometimes the recommendation is to put the patient on probation or immediately dismiss them if the professionalism issue is sufficient. And we assess how our fellows are remediated, or the effectiveness of our remediation protocols serially. So our competency committee will meet, after 2 or 3 months to see how the fellow did after the intervention was made. So here's a list of things that should prompt you to alert me if you encounter them. So as I mentioned, if you've identified a major competency gap, or if on the end of block IDER, the fellow has received an unsatisfactory or needs to improve in the conclusion summary, please alert me. I don't see the items immediately, so it's important to let me know. If there's recurring major professionalism violations, I also like to know. Well, yeah, and this is an example of how the ITER looks. So either unsatisfactory, needs to improve. Those are reasons to flag to me. Uh, those are the major reasons to contact me. But it's not wrong to contact me anytime if you're uncertain. Any questions on this? This is really just a gross summary of our policy on addressing fellows who are having these deficits. Thought I'd talk briefly about our committees because this is how we govern the program and build the program. We have a program committee that oversees all the major components of the program, like the educational resign, the learning sites, how we manage resources, how we assess and select and promote trainees. Um, we review the quality of teaching and supervision. We review our policies, and we ensure there's ongoing continuous quality improvement. Uh, and we meet on a quarterly basis. This is the membership. So I am the chair. Tony Wan is our scholarly lead. Hamish Nicholson is our HEAM path lead. Michaela Richards is our safety and wellness representative. So if you encounter a fellow who is having wellness issue, Michaela is the person to direct them to. Kirat Sidhu is our Surrey representative, and Erica Peterson is our VGH representative. And the AFC fellow actually sits in the committee as a trainee representative for themselves. If there's more than one fellow, only one of them will act as the representative. And each member serves a 2-year term. If you're ever interested in joining the competency or the program committee, please reach out to me because there's always space. You can be a member at large. Okay. Any questions so far? Okay. In terms of our policies, we have both program-specific policies and centralized policies. And policies are there to ensure that we're adherent to our mandate and to our vision and that fellows are safe and that also faculty are safe in a way. So policies, I think, is the foundation to our program. And we have program-specific policies on AFC Fellow Health and Safety, AFC Fellow Wellness, Supervision, selection of applicants, and new policy on fatigue risk management, which you should have received. And also, as I mentioned, fellows facing gaps in competency or professionalism. They are, as I said several times now, they're accessible through our Google Drive, and usually I'll send you a link at the start of the academic year to that drive for your access. Our duty as faculty is not to be, memorizing these policies, but know they exist. And if you're not sure if there's an issue related to one of these, related to supervision or fellow wellness, health and safety, the first place to go is the policy, because that'll tell you how this if truly there is an issue in the program related to that. There's a bunch of other PGME policies that are relevant to our program that I won't go through in detail, but they do apply. And our AFC policies are built or adopted from these centralized policies. Okay. Next, I'll talk about wellness resources. So, it's as we all know, training can be very stressful, and we might not be aware of fellows experiencing wellness issues unless we screen for it. And if we identify fellows who are experiencing wellness issues, I think our duty as teaching faculty, not only in this program, but as UBC faculty, is to be aware of how to support our fellows. So the first thing is, as I mentioned, being aware of our policies related to wellness. Be aware that they exist, and if there's a concern, then please look at the policy and see if truly something needs to be addressed. If a fellow is experiencing issues related to wellness, like they tell you that they're burnt out or there's an issue with mistreatment, etc., Michaela Richards is the first point of contact. She's our safety and wellness representative. You can also reach out to me, obviously, at any time. And also, it's important to be aware that PGME offers actually a lot of resources to residents and fellows um, for addressing wellness. So there's the Resident Counseling and Peer Support Office where fellows can receive free counseling, as the name implies, peer support. There's also additional resources for fellows through this office. There's the Office of Respectful Environments, Equity, Diversity, and Inclusion, where fellows can report on anonymously or however they wish on issues related to mistreatment or EDI. And there's the PGME Dean's Office. So we're well supported through PGME for issues related to wellness. This is an example of our UBC Wellness website, and it's very accessible. Any questions? I don't have access to the chat, but I imagine there's nothing on the chat so far. Finally, how do we communicate? Because it's important that we maintain a continuous line of communication as we build the program between the program governance and our faculty and our fellows. So what I've been doing so far, and please let me know if this works or not, but I usually, at the start of a fellow's new rotation at a learning site, I'll send a mass email to the faculty outlining these variables. So the learning objectives, the rotation format, how we assess the fellow, and access to our policies through a link to the Google Drive. Also, if there's any, I will inform you via email if there's any if your site has been reviewed by the committee and there's an outcome or a need for an improvement of sorts. Also, if there's any new policies or updates to policies, I will let you know, or obviously changes to the curriculum. I will inform you via email. And how can you reach out to me? You can always send me an email directly. As you may have noticed, for once per year, each site is reviewed, and part of that is a Qualtrics survey that the faculty completes on their evaluation of the learning site. So that's a really good way to give anonymous constructive feedback on your respective learning site. We have an end of year CQI dinner where faculty, the trainees, the admin can attend. And I think most of us here on the chat are faculty, so you're all invited. You should have received an invite. I think it's on June 30th at the what's it called? Cactus Club downtown. And that dinner is meant to be a forum for open bidirectional feedback or comments or brainstorming on ways to improve the program. And the last is I encourage you as teaching faculty to attend our accreditation review, where you can say whatever you want without me knowing to the surveyors. I think that'll be important so that we know how to improve ourselves going forward. And any feedback you receive is fed to the program committee and incorporated, and we do our best to address it. There's also UBC resources, so the PGME Dean's Office. Our program is officially under the Department of Medicine, so if you want to bypass me or if you are if there's something you're not comfortable telling me directly, Anita Palapu is the person to reach out to. So where's the program headed going forward? I think we've done a good job over the last 2 years of really building the program, building our skeleton and foundational blocks. But I think it's the future of what I see is expanding our applicant pool. Right now, we've had 2 excellent GIM fellows, but it'd be really nice to see some hematology fellows joining our program, eventually international or visa-sponsored trainees. Part of the issue with us not having as large an applicant pool as we'd wish is funding, but we're working on that. The next is also expanding our clinical sites. Fellows going to non-hospital-based clinics, maybe the New Salish Sea Clinic is an excellent example. We're also continuously building our curriculum. Um, we're looking forward to eventually building a longitudinal fellows clinic where fellows can actually follow their patients throughout the course of their year and follow, and mimic how an outpatient practice would actually be. They can follow the patient's investigation results, call the patient to summarize results, etc., arrange follow-ups, etc. So we don't quite have that yet. And as I mentioned, our didactic lecture series also um, needs to grow, and I anticipate that'll happen over the coming years. So thanks, everyone. I appreciate everyone's support in supporting this very new program. I'm happy to answer any questions or feedback. Um, Thank you.